You're watching Parker Success Academy Clinical Rounds with Dr. William E. Morgan.
Hello, I'm Dr. William E. Morgan, and this is Clinical Rounds. Today I have a very special guest, Dr. Robert Traeger. Robert, welcome.
Thank you so much. It's a pleasure to be here.
So this is a third part in a series we've been doing in relate to your book on sciatica, which was a fantastic read. In our conversations over time, we've talked a little bit about what happens when there's a spine injury causing atrophy of the multifidus muscles. And the multifidus muscles are protective muscles of the spine, and what's unique about them, of course, is they're primarily innervated by one primary nerve root or medial branch of the posterior primary rami provides most of the innervation. So if there's a reflex inhibition, we can actually see on MRI or ultrasound or EMG the atrophy of these multifidus muscles. What do you know about this?
Yeah, this is a really underappreciated topic, and we know from recent research that multifidus atrophy actually correlates with the degree of severity of lower back pain. And you can see it. I mean, you can see it easily on an MRI. You can measure something called the multifidus lamina distance, and you just pull up an axial of the MRI and just measure between the lamina and the multifidus muscle. And there should not be a big gap there. I mean, it should only be a couple of millimeters really at most. And if you're seeing 6, 7, I mean, that's huge. And basically that muscle has atrophied away and just allowed the fat to kind of replace it. And that's not good at all, because the multifidus is an important stabilizer of the lower back. It resists things like rotation and translation and all these intervertebral motions that we usually don't want to happen during day-to-day activities. It sort of holds our spine so the erectors can do the big lifts, if that makes sense.
So the original authors that really identified this, the Queensland's group from Australia, found that after an injury, the multifidus starts atrophying immediately, and it doesn't stop necessarily unless you take particular actions to treat them, so it stops the atrophy, the fatty replacement of the multifidus muscle. And what they found was the particular exercises, and then further from there, Dr. McGill's worked on this, and I think you've talked about some other researchers, how there's exercises you can do to provoke the multifidus muscles to not just stop them from atrophying, but for them to build up.
Definitely. I mean, there's a whole battery of exercises that you could do, and some of these might be better than others. It's really hard to say which is the best, but I like the anti-rotational exercises the most, like what we call the Pallof press or the anti-rotational press. Yes, exactly, just like that. And you're kind of fighting that rotation. And it's not to say rotation is inherently harmful, but there's certain patients that cannot tolerate it. Let's say you have a disc herniation or annular fissure or something like that. A lot of rotation, like swinging a baseball bat, golf club, stuff like that, can irritate it. So with the Pallof press, you're actually just holding neutral and fighting against rotation.
So you have a rubber band or a pulley that you're resisting against as it's pulling from you're pushing out away from you while there's pressure this way, and you're just preventing it from rotating.
Exactly. And then the other one is the anti-lateral flexion exercise group, and you have things like side planks, things like that, where you're fighting your body bending side to side. So both of those will activate the multifidus.
Or farmer walks, where you just carry a weight in one side and you walk with that, and it prevents that. And a nice functional motion with that. So those are some exercises that you would recommend that most people see. If somebody hurts their back, they're gonna have, in all likelihood, if it's a significant back injury, start having loss of multifidus muscles. So doing that, brisk walking is another good exercise for multifidus muscles. But also there's studies showing that when you adjust someone, it reactivates that, and that there's more electrical activity in the multifidus after an adjustment than there was before. And one study showed that increased activity lasted a week afterwards. So it's not just a reflex, but it's actually, as they would say, analogous to like rebooting a computer, reestablishing that pathway between the medial branch of the posterior primary rami and the multifidus.
Absolutely. There's actually another study that comes to mind where they did dry needling and found that dry needling in the multifidus increased the thickness during a contraction on ultrasound. So the people were better able to get a contraction out of the muscle after they did dry needling, which is super interesting.
It's and if you've seen a lot of MRIs, you'll see that a lot of times they don't even mention multifidus atrophy in there. It's so common, but it's if you hurt yourself, it's going to atrophy. Also, if you find somebody who has atrophied multifidus, they're much more likely to have back pain. So it is one of those places. If you want to know where to adjust, that's going to help you find out where to adjust. It's because it's removing that reflex inhibition, my understanding of this, so that nerve pathway reactivates. So adjustments and particular exercises are what we would recommend for those patients.
Yeah, it really helps prevent, I believe, recurrence of lower back pain. And you can sort of break that cycle of just pain and weakness that goes on and on and on, because when you get the multifidus weakness, now you have instability, and now you have a greater risk of injury in the lower back as well. So you really have to get these patients, their back stronger again so they can prevent the symptoms from coming back.
Now, I know you practice in a hospital, and you have anesthesiologists there who are doing medial branch blocks, where they go in and they anesthetize that, or they burn the medial branch, the posterior primary rami with diathermy, killing the nerve.
You know what? That is a really good question that I have heard come up and I have asked, and I don't think there's too much concern from the pain management providers, the providers that are doing these procedures, about multifidus weakness, and for certain reasons that are justified, in the sense where the multifidus is innervated polysegmentally, so it receives innervation from multiple levels. So there's this idea that, okay, if you have a little bit of injury with the ablative procedure, that it will still be able to function. And there's this also kind of a trade-off, like some people are just incapacitated in pain, and a lot of the providers we work with are very, very selective in who they're doing this with. And so there's some different considerations. That is definitely a possibility, though. I mean, it's definitely something you want to think about.
So, and when you say this, I know the studies show that there is some intervention for the segment above and below, but primarily it's one level. It has a very dominant nerve. It does get a little intervention from the segment above and below. They've uncovered that. I used to work in hospitals. I would give classes on this, and invariably I would have pain docs talk about how it's safe, and they'll say there's very little side effects. And I go, so what are you trying to do? Well, what does it innervate? Well, it innervates the facet. I go, what else? What are the other things it innervates? And I've never had a doctor give me more than 3. I think it's 9 things that nerve innervates: the multifidus, the intertransversus areae, the rotatories, interspinalis, the periosteum of the posterior portion of the vertebra, the inner spinous ligaments, all these things. And they had no idea that that's what they innervated. They were taught how to do this procedure. They're doing it every day, and all they know is it innervates the facet. And again, also the facet capsule, it innervates as well. So I've yet to meet anybody in the last 20 years who goes in and fries that nerve, who can tell me all the things they're killing innervation to. It's interesting. Ask an anesthesiologist what does that nerve innervate, and they won't be able to tell you.
Well, I mean, the other thing that's nice, though, with the pain management group that we're working with is they're very, very good about referring to chiropractic and also physical therapy. And so a lot of patients are going through a multidisciplinary approach. And so I think that helps prevent people from falling through the cracks and just getting over-reliant on like epidural injections and ablative procedures, where they'll get some relief for a while and then the pain comes back. I mean, the goal is to really rehab people, and you can go about that different ways, but I actually don't do as much exercise in the office as I used to. I'll give people some exercise at home, but I really lean on our physical therapy friends to help do that, spend more time with people. Also, aquatic therapy can be pretty helpful as well. Maybe not so much specifically for the multifidus like we talked about, but just in general with sciatic pain. Yeah,
when we talk about this, we want a global fitness and global core stability, if they're core stability, whatever that is. So, and that's where it's good to have chiropractors and multidisciplinary settings, so that if you walk into a pain clinic that only has anesthesiologists, guess what you're going to get? You're going to get a needle stuck in you. But if they have chiropractors, physical therapists, acupuncturists, recreational therapists, occupational therapists, you can work your way up until that person who, if they're in refractory pain and we've tried everything, what are you going to do? Pain is a very, very bad tormenting master, and I get it. I've been in pain before, so you're willing to do almost anything. Having a broad base of multi-disciplines is a very good idea, in my opinion. So anything else you'd like to share about this topic? Any insights that you have on multifidus muscles and just generally the muscles of the spine after injury?
Yeah, I'd say that in general, like when you're dealing with sciatic pain, I mean, you want to avoid high impact, ballistic kind of explosive motions, because sometimes it's just too much for the system to handle. You don't have the stability or the motor control or the strength to really deal with that. Let's say you're recovering from a disc injury. So we try to have patients do things slowly or do exercises that have a lower spinal load, like some of the quadruped exercises and the bird dogs and the Pallof presses and things like that, where there's actually not a lot of axial load on the spine, but you're still resisting forces and you're still using the muscles. And then you just progress from there and you see what patients' goals are and see what they want to do. And it really depends on a patient to patient. And you have to get a little creative sometimes, but you have to try to get people there step by step. And whether that's a chiropractor or yourself or working in conjunction with PT, whatever it may be, I mean, it can be quite comprehensive, and it doesn't have to just be one or two things that you have the patient do.
Well, thank you very much. And you've been listening to Dr. Robert Traeger, and this is Clinical Rounds.
Thanks for watching another episode of Parker Success Academy Clinical Rounds with Dr. William E. Morgan.